I am very happy to introduce to you my next speaker, Dr. Mona and Dr. Tarek Salah. Dr. Mona is professor, faculty of Dentistry, University of Alexandria, and Dr. Tarek, lecturer, professor of fixed prosthodontic in Shamsi University. The title of the lecture is Behind the Smile, Leading from Aesthetic Failure. Okay, you can start.
Good morning, everyone, and thank you so much for the introduction. I have the pleasure of being with Dr. Mona Ghoniem today in this outstanding lecture, because every time we try to give a new perspective for our aesthetic work, and we've been together as duettos for 10 years now. It's been around 10 years doing these kind of lectures, and we hope to shed a new vision on the failures and the difficulties we encounter in our everyday practice. Let's go.
Good morning. Good morning, 6th of October University. Congratulations on the first Congress being held under the deanship of my dear Professor Mohsen Abil Hassan. This is to be commended, because it's not easy coming from Alexandria University, knowing the challenges that encounter us in preparing such prestigious congresses. So congratulations on your first Congress. And of course, congratulations to Dean Mohsen Abil Hassan. Thank you so much for the invitation. I cannot but say I am honored to be lecturing in front of my mentor and my professor that I have learned so much from, not just in scientific research, in clinical practice. He was my mentor in University of Minnesota in Minneapolis, Professor Omar Zidan. I have learned a lot. I hope I'm making you proud. It means a lot to me that you are attending our lecture today. He was the head of the digital Tarek units in University of Minnesota, and this was back in 2004. So a long journey, and I hope we're going to present in front of you scientific, well-documented clinical cases. Of course, aesthetic dentistry has gone beyond the realm of pure aesthetics and has become an integral part of any treatment plan, not just in restorative, fixed prosthodontics, and of course, we've got the ortho, we've got the perio, the surgical and the oral surgery and the maxillofacial as well. They are using now digital dentistry and with the cornerstone of aesthetic dentistry in planning. Of course, starting any treatment plan, these are all patients of ours that we have worked together on. So they are our copyright, and we do have their consent, their agreement to place their pictures. Aesthetic dentistry, yes, is a very big subject, but aesthetic and functional aesthetic planning is very important to start with the end in mind, not just for aesthetics, but to deliver functional and biologically sound restorations.
So, once she has the mic, it's very difficult to get it from her, but I enjoy listening to her lectures all the time. So, let's just begin with the aesthetic planning in mind, and we know that it is the key element in success for any aesthetic case. If you don't plan well, you cannot predict the outcome. You cannot see the end in mind, as just Dr. Mona said, and of course, it's very risky to finish the case and then at the end see whether the results will be satisfactory or not. So you have to concentrate in your aesthetic planning, do every step very carefully, integrate everything. The facial integration is not to be taken lightly. It's very important because at the end, we need to have harmony in every step. We need to have harmony with the teeth and soft tissues and, of course, the facial structures all in all. Harmony all around and balance between the right and left sides. So if you don't plan well, you cannot guarantee the results. And as you can see, planning starts with some data collection at first, pictures and clinical examination and scans, different scans, intraoral and facials. We have different tools today. Digital dentistry has provided us with several tools that can help us in the integration of all our disciplines together, and of course to make use of every tool to reach the best outcome.
Let me ask you a question. Of course, we have been introduced to the digital world not quite a few years ago, and now every graduate student hops into the digital world. This planning was one of my postgrad students, Dr. Salma Imam. I was with her on the case, and they start thinking, once I know digital scanning or I know how to take photos, I will be able to do perfect or deliver perfect restorations. Of course, this is not the case. Let's go back to the main cornerstones of aesthetic planning, because I will show, or we will show cases that there are pitfalls in planning. Meaning, the four main cornerstones would be facial aesthetics, macro aesthetics, micro aesthetics, and gingival aesthetics. During planning of this, we could have misconceptions of, like in this case, it is a beautiful case. When we look at the case, this is of course helping us with the facial planning, and all the scanners are hopping in with the mid-face scan, orienting it with the intraoral scan. Yes, we are being helped with digital dentistry, but when we look at the final results, it is a beautiful case. When we look at the restorations, but there are some corrections that could be
aesthetically
done.
It's beautiful, no doubt about that, but let's take a look at the occlusion. So it's not just about aesthetics. We have to think about all the factors together: biology, function, and aesthetics, of course. Beautiful aesthetics, but a very small pitfall at the anterior guidance with the protrusive function. We have a premature contact on the left central incisor. This was left behind. We cannot leave it like that. This is, of course, a correctable mistake. It's easy to correct even after bonding, but what I mean is you have to look in a profound way, not just for the aesthetics. If you perfect the aesthetics very well, but also you have to think about the biology and the function as well.
Not just that, when we look at this case in the anterior zone, we did do gingivectomies or surgical crown lengthening, but when we look starting from the first premolar onward to the posterior, you do notice that the gingival aesthetic line is not harmonious. So to be very meticulous in planning and actually executing the treatment plan, yes, I will say it's a beautiful smile, but again, there are some mistakes. This is just simple mistakes. We're going on to bigger mistakes. And when we teach our students about the proportion of the face and the proportion of the teeth, when we look at this patient, and of course they use the recurring aesthetic dental ratio by ward, etc., but then when the restorations were delivered, that's what we got. Of course, when we look at the facial proportions in relation to the oral smile or the oral cavity proportions, I would say this is not very.
Yeah, I think it has several mistakes, no harmony whatsoever, and
facial proportions.
Maybe the teeth, if we look at them separately, we'll like them, but in a holistic manner, no, of course, it does not conform with the face, with the whole dental and facial structures. So it's a failure at the end. We learn from that, of course. We keep learning from our mistakes.
Now, This is a case of mine a long time ago. This is my patient. She's a 50-year-old woman. That was probably 8 years ago, and I'd like to show her because she does, this case was a challenging one, but it turned out to be very pleasing to the eye. First of all, with those lips, that's what I get a lot nowadays on my clinical chair, the plumpy lips, etc. And of course, the first genesis of any smile would be placing your incisal edges in a proper way. And I couldn't even get her any tooth reveal. I told her to go back to her, I don't know, but I'm not going to say the cosmetic plastic surgeon, dermatologist. Yes. And I made her remove those fillers so she could get a beautiful, harmonious, young smile, and I can get more tooth show. And also, the incisal edge position was compromised. You can...
Yeah, it affects very much the phonetics, of course, not just the aesthetic part. And it's a very common mistake we see with our young students, for example, that the centrals, they like to show them more, they like to increase the length and protrude them a bit, and all that affects the not just the aesthetic appearance, but of course the phonetics. The F and V sounds are very critical with the position of the central, and of course the S sound, and it's very common mistake, unfortunately.
And also your anterior guidance.
Yeah. Of course, the occlusion plane. Also.
Exactly. Now, another patient, and this is a mock-up. And of course, when we say we place mock-ups so as a test drive to our final restorations, it is you have to be looking at the pitfalls or that could be predicted later on. Remember, the APT technique introduced by Galib Gurel a long time ago was actually for predictability and stepping wisely in each case. Now, when we look at this case, of course, the emergence profile, I have to make sure in my final restorations is well corrected. I have to make sure the incisal plane is well corrected, and the buck teeth is, do you think those buck teeth could have anything to do with the preparations?
Well, actually here we have several mistakes in terms of the triad of aesthetics, function, and biology. Because aesthetics, maybe we can extract some of the pitfalls regarding the ratios between the teeth. The red proportion, of course, it's not that accurate. The emergence profile is not that good. The contours cervically, we can correct all that during the test drive phase that we're facing here. And of course, we can see here that the intradental papilla is squeezed between the teeth. So biologically, it's not gonna work like that. We have to increase the embrasures between the teeth. These are common mistakes. But we have to bear in mind, it's very common that dentists will tend to increase the length of the incisors to show them more, and it's more beautiful, showing from the upper lip. But bear in mind that this will affect your anterior guidance and will cause more disclusion in the posterior teeth, so the chewing efficiency will decrease. You have to integrate that. If you're going to increase the length, check the guidance, check that it is not that steep, and you will have to increase a bit the inclination to preserve the amount of disclusion, posterior disclusion, or else you will have more disclusion posterior. It will act as an interference for the patient, and he won't be able to chew the food efficiently.
Now, failures don't just happen with in indirect restorations. They also happen, and even more commonly, in direct restorations. Of course, we're also right now at this stage of talking the external surface. We're going to go deeper and deeper. When this patient, it's matching that she came in with an old composite resin on the right central, and it was supposed to be replaced. And remember, going back to the basics, when the IDIC first told us about the final layer of the enamel composite resin to be placed on the facial margin, not to exceed 0.5 millimeters, so we don't get that grayish effect. Again, going back to the palatal shell, it's very important, like in this case, to oh, sorry. أنت عملت كده؟ When we look at this case, this patient needed an amber or a milky white. Excuse me. صوتكم واضح ورا هنا. ممكن نوطي الصوت؟ أنتوا اللي صوتكم واضح. So we're supposed to be very careful in selecting our enamel palatal shell because of the darkness of the oral cavity. Of course, when we look at the final restoration on the right central, you can see that this was not being taken into consideration, and so what you got was a grayish effect. On the labial surface, another patient of a missing incisal edge, or what we call a traumatic class 4. And this shows go ahead, you can. You can see that grayish effect, and that is probably because the 0.5 millimeter enamel shell or the enamel layer that was placed at the surface was beyond 0.5 millimeter. Mind you, it's very challenging to place direct composite resin restorations, especially when you have a lot of dentin and enamel being replaced because of so multiple factors. I will not go into them because we're going into more challenging cases. Now, this patient shows the importance of the biological dimension, and it's very important that you control the plaque and the risk factors that could cause on the long run periodontal breakdown, and of course you will have a failed aesthetic result and a biological result. So you have to be very careful in staying or moving at a slower pace with those patients, because at the end of the day that biological dimension will cause you failure.
We will never have success unless we have both the biology and the aesthetics integrated together. So starting from the planning first and then the execution, we need to take care of every step. Preparations, we don't need to place the margin subgingival unless we have major destruction in the tooth structure, of course, and always work equigingival, preserve the soft tissue, wait until it heals. The needed period for complete maturation of the soft tissue, it's very important. Preserve it while preparing, while taking impressions if you're taking a physical impression. And of course, the provisionals are very important. They have to be very smooth, the margins adapted and well polished so that the gingiva can heal around the margins very well before the bonding step. And also the final design of the veneers should be well contoured, no over contouring. The embrasures should give a very good space for the interdental papilla, and at the end you need to use materials with very well tolerated by the soft tissues. Well glazed and highly glazed ceramics are very important at this area, or at least if you're gonna adjust anything on the bonding step, then you have to polish it very well. You have to include in your armamentarium the polishing kits necessary for making surface glaze or surface polish, just like glazed ceramics at the end.
Okay, this patient presented with multiple old composite resin, and this we are showing this case because of the importance of the gingival zenith. Again, we're still in the biological dimension or the pink aesthetics, and when we look at the final result of this case, she will have a slanted smile. Looking at the laterals and not taking into consideration the proper gingival zenith will give you at the end of the day a compromised gingival aesthetic line, what we call the gal. Can you look at this and look at the slanting of the smile? So every step is evidence-based. Every step is not to be taken lightly, and sound scientific information that we were taught has to be followed
And let me just say that
vigilantly.
this goes back to the beginning of the planning step, because you did not plan well, you did not take the curves from the face very carefully to integrate everything, the eye, interpupillary line with the teeth, incisal plane and gingival plane, everything should be conforming together. And you can even manage the upper lips later at the end with some botox and fillers whatsoever.
Now, we always place this slide in our presentations because this is probably the most complicated and the most common cause of all failures, and it is occlusion. Now, you want to say?
Yeah, well, it's the same idea that everything should start with the treatment plan. A very solid treatment plan is very important to make sure that the final outcome would be reliable and predictive for the patient. So occlusion is not to be undermined while planning. It's actually, it is the main cause of failure, because you can make very nice veneers, very nice anterior restorations from an aesthetic point of view, very well bonded, and everything is very nice, and the gingiva is beautiful, and at the end it fractures or rebonds, and the most common cause here is occlusion. You left maybe a premature contact, some interferences, but most commonly the guidances are not balanced. This is the important thing we have to take care about while planning.
Okay. I'm going to show a case of mine, and this is what I'm working on at this stage in my private practice. This patient, these are pre-operative photos that he has sent to me after he came to me. And probably this case shows a lot of failures that we need to correct. And
but let's talk about this. Let's go back and talk about this picture. Let's stop here and see the amount of failures done in this case, because the original case is very difficult. It's not an easy case. You have some midline shifts and cross bites. The occlusion is messed up. Everything needs correction. But at the end, when he went to a dentist, I don't know, when we're not going to talk about him, but at the end, he's done some crown and bridge work on all the teeth. They have been all crowned, and trying to adjust the occlusion, it got completely messed up. حصل حاجة؟ طب دوسي على play كده.
So these are his preoperative photos. I need you to look at this patient very well, because these are the type of cases I personally get nowadays in my clinic, and I think Dr. Tarek the same.
Yeah, that all the time.
I don't think he could have done some orthodontic work, and he's young, by the way. That's what he came with.
But all types of failures: biological failures, aesthetic failures, functional failures. Nothing is correct, actually. And the right side, actually, the bridges is continuously folds. So the teeth, no retention. This is a minor thing, but we can look all around. Nothing is good. So we will have to remove everything and start the planning from the start, as if nothing has happened before, and try to correct the mistakes.
Let's
see
stop
the
here,
teeth.
and his bridges, they were connected. And please remember his preoperative photos, because this is a very challenging case. Not just aesthetically. Aesthetically, we can work upon the aesthetic dimension very well, but it is the foundation that lies beneath the restorations. And there were so many questions in my mind. Where will I start? Of course, I'm going to rebuild the foundation, which is what I did. And at that stage, we have a beautiful article by some of our postgrad students, Ashri Ital, that introduced us to a technique that was what was followed in this case. And it is, number one, to record. There are two ways to manage complete mouth or full mouth reconstruction. A patient can come with loss of VDO, but the patient, again, that needs full mouth reconstruction can come without loss of VDO. And at that stage, the management is very different. Number one, we followed the Hobo twin stage technique, and it is, number one, to record your VDO and your CR, rebuild the foundation of those teeth, and then after this, do a bonded transitional restoration. This was a private case or functional prototypes, and then we're going to record again, but I want to maintain the VDO and the CR and then recheck again after putting my BTRs. So, at that stage, you remove the anterior bonded transitional restorations, maintain the posteriors by a composite resin jig, and so your vertical dimension of occlusion is preserved by the composite resin jig, and then you take a buccal scan on both sides, mount it on a digital planning software, CBCT wide view was performed, and then again designing at the final measured VDO and then placing your restorations. This was a very challenging case, but I'm still working on it, by the way. I need to ask Prof.Tarek, when you place those restorations, do you want to place them, would you place them in single units, or would you place them in bonded, connected units?
Well, to answer your question, it depends on the condition of each tooth, of course, whether it needs splinting or not. Usually we prefer that each tooth should be restored by itself, not connected, but sometimes in the sake of retention or protection of the periodontal condition, we can make some splinting together, maybe. But all the time, if you have I mean well-supported teeth in terms of periodontal support, then you can use them separately, provided the occlusion is well balanced so that no interferences on that particular tooth that might cause some tilting or drifting of the teeth.
And now also let's go a little bit deeper. The condylar angulation at the anterior region will be different in this case than the posterior one. It is by evidence-based literature, it recommends that we do a steeper condylar inclination in the anterior zone.
In relation to the condylar guidance, of course.
Now, when we stop here and listen to what we have just said, it is not easy to treat
such cases now.
Such cases. Yeah. You have to be very careful, because what we get, I've been 33 years now in practice, 33 سنة, and some of our professors here are even longer. So, Dr. Tarek, what we see today, and I'm working on failures.
Yeah, all the time. Actually, I rarely get a fresh case at the clinic or even at the university. Actually, we always get some failure cases, and we make cases all the time. But what I need to say when managing these cases, that you need to have a roadmap. You don't just go ahead and work, remove and prepare and take an impression. No, you need to have a roadmap. You can work on it, and some stops along the way to recap everything and make sure that you're going right, so that you can even take a detour or something at the right time. Test drive is very important. You have to try the final restoration you need before going into the final stages.
Of course, teeth preparation or the tooth prep itself, I will probably need a separate lecture on its own, because you can under-reduce, and then there are sequences for this, or you can over-prepare, under-prepare, and then you've got your enamel and the dentin, and this will take us to a very important step that we will end our presentation with, and it is the bonding. Again, the weakest link behind all these restorations is the bonding. Mind you, This is just a summary
of the
what we
roadmap
need
we've
to-
been talking about.
I'm not going to, I don't think we have enough time. We have presentation.
Yeah.
We have to end it, but forget this part. I'm just going to stress upon
let's
this.
concentrate on bonding, yes.
Yes. Just in a nutshell, when I was doing my PhD with Dr. Zidane in Minnesota, we were working on bonding, and it was to different substrates, etc. And remember, composite resin restoration, the failures lie upon two main cornerstones: polymerization shrinkage and that adhesive layer or adhesive zone in between. When you've got ceramic bonding, you have four interfaces that you can encounter failures in. One could be enamel and dentin or both, because you could do it inlays and onlays and overlays, etc., with the bonding system or the bonding resin that you will be using. Also, between the bonding resin and your resin cement. Also, another interface between the resin cement and the silanated surface. And then you've got your fourth interface between the ceramic and the hydrofluoric acid etched and the silanated surface. So in each part of the four interfaces, there are many failures that you can encounter, but it is not our main concern in this present. I think we should give a full 2-day course على فكرة على failures.
On bonding, yes.
لا كله على failures.
You just have to understand the difference between the materials and how you should treat each one. I know it's not difficult, and it's an old science now, how to treat the lithium disilicates and the feldspathics and the leucites. It's not that difficult, but please abide to the instructions, please. Because sometimes I see people that don't go through the instructions well, and that's why it is part of the failures. What about if you have some dentin on the surface? Would you make an IDS, an immediate dentine sealing, or is it not important? What do you think?
Of course, let me just stop and say a beautiful hybrid layer here. That's what we look for. This is courtesy of Professor Zidane and myself. They were these SE field emission scanning electron microscopy photos. This is one dentinal tubule, was highly commended at the University of Minnesota in Minneapolis. It shows you this is one resin tag. Can you imagine? I don't know if you showed those photos, Professor Omar.
Yeah, this is more than 20 years ago, I think.
Yes.
Yeah.
And of course, what we teach our students in adhesive dentistry, this is my area in University of Alexandria, and when we say each step you can fail, it's very technique sensitive. Look at the collagen web. It is beautiful, open. When John Conca talked about the bonding, the wet bonding technique, of course, I'm not going to name all the scientists, but of course, Sano, Nakabayashi, etc. But you want to have that picture clinically. And I place this, of course, you want to take it from the multiple factors that influence, your restorative material can influence your bonding system. I've been to Professor Tarek Salah's clinic and my clinic. You have to have multiple ones because each clinical situation you will be using different chemistries. It's all about chemistry. Preparation designs, if you've got more dentin, less enamel, etc., you're going to pull out that resin cement kit and necessary bonding figures that you will be looking for, but never. You want to talk about never mix?
I don't like to bond anterior teeth, anterior veneers, so in particular with dual cure cements. Why would I do that? I can simply bond them with composites, with flowable or even heated composites or softened composites, and light cure cements, of course. But dual cure cements are more for larger restorations like inlays, onlays, and crowns, of course. They are suited better for them. And if you're using self-adhesive resins, I like them, the self-adhesive cements, but not with veneers. We don't have to. With enamel in place, we can simply etch and bond, then just place flowables. It's easy and it's very durable, by the way. So
Wrap it up.
we're gonna wrap, yeah.
This is just to show that if you're going to prepare for veneers, this was a veneer case. Mind you, you have to do a try-in. And when you start your try-in, because those veneers will look grayish on gray models, yellowish on yellow models. If they're outside in your hands, they will look lighter. So you do have to use, this is one point that could be misconcepted, is that the color of the veneer kit itself starts with clear resin try-in pastes and then add 5% increments, 5% increments. احنا قربنا. I'm not going to, you want to talk about the silane?
No, yeah.
Okay. I use 2 bottle silanes, unhydrolyzed silane, and I mix them with the other bottle which is aqueous acetic acids, because if you do use pre-hydrolyzed silane, and I know many of you do, they're not as stable. They can become turbid. The solvents could evaporate, and xyloxane oligomers could form, which is not as active. You need the silane to be active. طيب when the ceramic خلاص بقى كده, I think it's enough. Let's just say key takeaways.
Yalla, go ahead.
ماشي. Of course, consider, I'm not going to say failures, but pitfalls or failures, a learning journey. We could learn from them, be more precise, more predictable, more successful. They are golden opportunities. It's a learning opportunity for all of us, and it's a clinical learning opportunity. Mind you, it's a gem to learn from your failures or your pitfalls, because at the next stage, you will not do it again. You'll be a better dentist, a better clinician.
Yeah, we need to learn from our mistakes, of course, and be sure that you need to think about each aesthetic case individually. It's completely different from the other. There is no single pathway for every case, but you have to place a roadmap you can work on. And at the end, we aim for consistency in our work, predictability for the end result, and of course, conservatism all the way.
Thank you very much, the Egyptian Dental Innovation Conference, for having us today, and enjoy the rest of the day. Thank you so much.
Thank you so much.
Any questions? In behalf of the scientific committee of the conference and the board of the conference in all, thank you, Dr. Mona Ghoniem. Thank you, Dr. Tarek Salah Morsi, for, first of all, for attendance, for coming, and second, for very interesting lecture regarding the new aesthetic era. Thank you very much.